Hello and welcome. We are John and Wendy Sloss from Appleton, Ontario, Canada. Our son Brody has 48XXYY. We are both volunteers for the XXYY project. John is also a member of the AXYS Board of Directors. The XXYY project functions with the goal of helping all boys and men with XXYY live full and productive lives.
We personally met our next presenter in 2019 when she volunteered her time to present her doctoral thesis research findings to a room full of XXYY families. Her study on XXYY men and their quality of life offers a unique insight into the lives of adults with 48XXYY. She is such a warm, respectful, and sincere person, and we are truly appreciative of all her hard work and dedication. The XXYY project, through the Ryan Scovell Research Fund, was a proud sponsor of Amy's study. We feel her work will aid in future research to help boys and men with XXYY in awareness, understanding, and support. We are delighted to introduce Amy Blumling.
Hello, my name's Amy Blumling, and I'm a clinical instructor at Emory University. Today, I'll be presenting the work I did for my PhD dissertation defense this past year on the relationship of physical function and psychosocial health on quality of life in individuals with 48XXYY. Before we get started, I just want to thank the funders for this study, the XXYY Project, and the Emory Laney Graduate School. So to begin, I'm just going to present a little bit of information related to sex chromosome aneuploides, or SCAs, and then the specific SCA that I worked with for my dissertation, 48XXYY. So as you all likely know, sex chromosome aneuploides are our variations in the number of X and or Y chromosomes, with an individual having fewer than or more than the standard pair of X or Y chromosomes. There are a variety of different SCAs, with the most common being Klinefelter syndrome, or 47XXY. There are also tetrasomies and pentasomies of SCAs, although they are a little bit more rare. So the topic of my dissertation was the specific SCA tetrasomy 48XXYY. And the reason for that is that in addition to being more rare, it's also less studied. So men with this condition have both an extra X and an extra Y chromosome. This disorder is estimated to occur in 1 in 18,000 to 40,000 male births. Individuals with SCAs may present with both increased symptom frequency and symptom severity, dependent upon the individual, but as compared to some of the other SCAs. So just to briefly highlight some of the physical symptoms associated with 48XXYY, many individuals with this condition experience hypergonadotropic hypogonadism, which is that impaired response of the gonads to gonadotropins, causing that decreased production of sex steroids, one of which is the sex steroid testosterone. So individuals often have experience variations in testosterone production. Because of testicular pathology, some men with 48XXYY will also experience reproductive health issues, and specifically issues around fertility. Poor dentition, including a tendency to develop dental caries, is also common. And finally, tremors are also frequently reported in this SCA. For the neurobehavioral and neurologic, neuropsychological symptoms, they're also quite varied, but some can include symptoms of autism spectrum disorder or an actual diagnosis of ASD, general social cognition difficulties like difficulty interpreting social cues. Some sleep disturbances have been reported. Intense sugar cravings have been reported both anecdotally and in the literature. Some individuals might also experience some learning and or intellectual disabilities, delayed speech or motor skills as infants, impaired motor skills and coordination as adults, and finally, white matter hyperintensities and enlarged ventricles in the brain. So specifically, I'd like to point out that individuals with 48XXYY are also at an increased risk for anxiety and depression. So in the largest study thus far with 95 individuals, over 46% of the participants had some type of mood disorder, with generalized anxiety disorder being the most common at over 21%, and depressive disorder in about 17% of that study population. So all of these numbers are higher than the national average. The current literature on 48XXYY is somewhat limited, both in quantity and scope. So the vast majority of reports are physiologic or psychosocial descriptions of the disorder, primarily as described by clinicians and less frequently, sometimes parents. Many of the studies are case reports or case series with relatively small sample sizes. And then finally, that early literature on 48XXYY and all SCAs in general, particularly coming from the 60s and 70s, is subject to really significant ascertainment bias, as study participants were often recruited directly from penal institutions and hospitals specifically for people with intellectual disabilities, creating a really skewed picture of what SCAs look like. So research on 48XXYY is also limited in terms of self-report surveys, offering a rather limited patient perspective. And there are also very few studies that utilize qualitative methodology or studies evaluating quality of life in this specific SCA. So in light of that information that we currently have available on 48XXYY, my dissertation study was undertaken to explore how men with 48XXYY perceive their physical health, psychosocial health, and overall quality of life. So the aims of the study, or the specific questions that I was trying to answer, were to describe the self-reported quality of life in men with 48XXYY, to describe self-reported anxiety and depression in this condition, and to explore daily living issues, physical health concerns, and psychosocial health concerns that might contribute to quality of life. And finally, my exploratory aim was to utilize mixed methodology and triangulation of results from surveys and interviews to contribute to sort of an explanatory model on the phenomena that I had observed. So our study methods and design. So the design for my dissertation is called a cross-sectional descriptive study using a mixed methods design, which means that I used both quantitative measurements or surveys and qualitative measurements or interviews. So the qualitative piece is capitalized on this slide to indicate that that was the primary focus of the study. So we had 22 participants enrolled into the quantitative section of the study to complete surveys. And then 10 people were chosen out of those who had completed the surveys to then participate in in-depth interviews. So data analysis of all of these variables involved identifying what are known as variables of interest in either or both the strand of the study. So looking at what's important or meaningful from the quantitative surveys and the qualitative interviews. So based on those assessments, the variables of interest ended up being the socio-demographic variables: age, living arrangement, employment, and education. And for the survey variables, we had the Beck depression and Beck anxiety inventories, and then 4 subscales from a quality of life survey called the SF36. And that quality of life subscales that were most important included physical functioning, energy and fatigue, emotional well-being, and social functioning. And then finally, the interviews, the qualitative portion, asked questions of participants that were similar to all of those previously mentioned topics. So following this, did the data analysis to get results from both the quantitative and qualitative strands. The first half I'll be going over is the quantitative strand, or the surveys that participants completed. So to begin, I analyzed the socio-demographic characteristics of the sample Individuals in the study had a median age of about 26 and a half years old, and all participants self-identified as Caucasian. Slightly less than 75% of the participants lived with their parents or in a group facility, with the remaining individuals living independently with or without roommates. With regards to employment, overall, the majority of participants had previously been or were currently employed. For education, there was a really wide range of achievement, likely due to the wide age range that I had, but the majority had completed some level of post-secondary education. And you can see here that we had the majority of participants from the USA, but we also had some participants from Canada, Australia, United Kingdom, Germany, and Brazil. So now transitioning to those survey variables of interest that I mentioned before. So these charts are going to summarize the descriptive analysis of the Beck depression and the Beck anxiety inventories. And they're here in both their total continuous score and their categorical score. So the figure on the left is going to be the continuous score of the variable from 0 to 63. So as you can see, most participants scored around 12 to 15 for both depression and anxiety, with some individuals slightly higher or lower. And then the figure on the right shows how that continuous score is categorized by the developers of the inventories of the surveys, how it's categorized into 4 groups: minimal, mild, moderate, or severe for both depression or anxiety. So about half the participants were in the minimal categories for both depression and anxiety, with the remaining half having some level of depression or anxiety ranging from mild to severe. So in some of the analysis I'll be showing next, I combined these 4 groups back into 2 total groups for each condition: not depressed, depressed, not anxious, or anxious. And I was pretty lenient in what was categorized as the depressed or anxious categories, anybody who had symptoms ranging from mild to severe, because I wanted to be inclusive that was of anyone showing any kind of signs of some level of either condition. So these are the SF36 quality of life scores for the 4 subscales that appear to be the most important in this study: physical functioning, energy and fatigue, emotional well-being, and social functioning. So this scale is a little bit different. It's from 0 to 100, with the higher number indicating a better quality of life. So higher quality of life is associated with higher numbers here. So what you're seeing in red is the average total score of the participants in each of those 4 categories. So you can see that generally participants scored pretty well on social functioning and emotional well-being. And in energy and fatigue, that 3rd red bar there was rather low comparatively, indicating that they had more problems with that quality of life component. And then physical functioning was the highest of all the scores, indicating better quality of life there. So once I had the averages and those other descriptive statistics of the main variables, I was also conducting my qualitative analysis of the interviews. And I discovered through talking to participants that living arrangement and employment were really important factors for participants. So I specifically conducted some analyses to evaluate any differences in depression, anxiety, or quality of life subscales, those 4 that I keep mentioning, if they varied by living arrangement, either living with parents or in a group facility versus living independently with or without roommates. So as you can see here, the Beck depression inventory is that variable on the right-hand side of the screen here. That score for individuals who lived independently was significantly higher than individuals who lived with parents or in a group facility. So that meant that individuals who lived independently might be more likely to have a higher depression score. So there weren't any significant differences between living arrangement and anxiety variable, nor were there any differences between living arrangement and the quality of life subscales. And then you'll notice that employment isn't addressed in this slide, and neither is education, because they weren't significantly related to variations in living arrangement either. For employment, participants were dichotomized into currently or not currently employed, and then evaluated for relationships among survey variables. So the only two statistically significant differences in the quality of life subscales were physical functioning and emotional well-being. So individuals who were currently employed were more likely to have higher physical functioning scores. And they were also more likely to have higher emotional well-being scores. So again, education isn't listed here as it wasn't significant related to employment. And in fact, educational level wasn't statistically significant with any of the survey variables with depression, anxiety, or quality of life. All right, so for the second half of the results, I'll be presenting the qualitative interviews section. Okay, so in the qualitative interviews, participants were initially asked to describe their physical, psychological, and social health as all separate components of their overall health. So when participants described their physical health, over half perceived few to no physical health issues impacting their daily lives. They had a relatively positive outlook on their physical health, but it was often framed in the sense of comparing themselves to others with more severe physical health challenges. With regards to psychological health, some participants described circumstances where they felt relatively happy and didn't have many psychological concerns. However, others described some pretty significant experiences with anxiety and depression, and that was often related to problems with intimate relationships and friendships. Frustration and anger were also reported, but were more related to issues of independence. However, participants were able to navigate any of those negative psychological symptoms through relatively positive coping mechanisms. For social health, participants described this as a complicated yet really influential part of their overall quality of life. So positive aspects of social health included having meaningful, reliable friendships and intimate partner relationships. As an example of perceiving no physical problems, one of my participants said, "I don't really have any problems. I don't know, I'm not in a wheelchair." And as an example of issues relating to anxiety and depression, this participant said, "If I have to think too much of something that happened back in the day, that's what caused me to have depression. I would think too much about a relationship that I had before and why it ended. I would think too much about committing suicide." So in addition to analyzing individual components of health, topics that were interconnected between multiple health components were also analyzed. So for physical, psychological concerns, over half the participants described issues with self-control and dietary choices, mainly related to increased sugar consumption. So some of those issues ranged anywhere from stealing sugary items from stores to serious physical health consequences from eating too much sugar. For psychological social health, or psychosocial, there were two common themes here: the role of confidence in socialization and difficulty interpreting social cues. So without prompting, over half the participants mentioned the concept of confidence when discussing their psychosocial health and how having confidence was associated with positive intimate relationships. However, the lack of self-confidence appeared to be even more impactful and was viewed as detrimental in one's ability to find an intimate partner. Social and physical health concerns were expressed as a strong desire to be understood and accepted by others, especially in terms of others understanding all of the needs that arise from having 48XXYY. So as an example of some of those self-control and dietary issues, this participant mentioned, I consume more sugar in a day than most kids or young adults consumed in a week. Relating to interpreting social cues, another participant mentioned, I can't read what people are saying, and I think they're being mean with me all the time, but maybe they're just trying to explain it to me, but I don't understand them. When participants were asked to describe their thoughts on their overall quality of life, or that aggregate of the physical, psychosocial health, many expressed that it was relatively positive and they were satisfied with their lives. However, despite the positive descriptions overall, participants did mention some very specific interrelated health factors that had the potential to negatively impact their quality of life. For example, reproductive health and fertility were commonly described as a troublesome physical and psychosocial health symptom. So reproductive health concerns, interestingly, weren't necessarily bothersome to participants in the traditional context of a desire to have children. The main concern was that participants' partners might perceive them as less than or undesirable because of their inability to potentially provide the partner with biologic children. Additionally, tremors were one of the most common physical health issues. But again, from the participant's point of view, this issue wasn't inherently problematic in and of itself. It was when it was viewed negatively by an outsider that tremors became then problematic for the participants. And finally, almost all the participants described having to use testosterone replacement therapy, or TRT. It was frequently described not only as a physiologic component, but also a psychosocial component, as they experienced noticeable differences in their energy and emotional states related to using or not using TRT. So on the topic of reproductive health and psychosocial health, this participant mentioned, most of the women I know don't want to date me because they want kids and I can't give them any kids. I feel like I'm a spotted tiger in a field and everyone who has a partner is straight. How others perceive tremors. This participant mentioned that a time he had been, a police officer had asked him specifically, why are you shaking? And he replied, well, I have this weird chromosomal disorder thing that I can't do anything about. And they always think that you're hiding something because your hands are shaking. So finally, although not expressly asked of participants during the interviews, the subjects of independence and relationship with family members, as well as the importance of employment, became clearly very important themes. So almost all of the participants organically brought up relationships with their family, and especially their parents, and how these relationships impacted their sense of independence. So the main themes that emerged from this topic were parents' roles in monitoring their son's health and trying to balance this adult-child and parent relationship, balancing that control versus support. In addition, employment emerged as another topic of high importance. So participants primarily enjoyed the sense of purpose and financial independence that employment gave them. But for those lacking employment, it was a very difficult situation that really negatively affected them both financially and emotionally. So as an example of the relationship with family members, this participant mentioned, nothing about me I've worried about. It's all my parents. My parents know me better than I do. As an example of the importance of employment and the devastation of lack of employment, this participant said, I feel down on myself all the time because I can't have a regular job. So my anxiety is pretty high. And now I will present some final conclusions. So overall, that quantitative or survey strand of the study revealed some higher than expected rates of depression and anxiety as compared to the literature when participants were dichotomized into those two groups of depressed, not depressed, anxious, or not anxious. So 50% of participants met the criteria for depression in the study based on this, the Beck Depression Inventory, and 45.5% met the criteria for anxiety. So the discrepancies here between what's published in the literature could be due to the fact that the mood disorder rates mentioned at the beginning of the presentation came from a study that utilized medical records and parent reports of psychiatric diagnoses, as opposed to self-reports of affected individuals. And again, the surveys that I used are not necessarily diagnostic tools. They are just screening tools for signs and symptoms that are related to depression or anxiety. There's also the possibility that the splitting score or the cut score for cutting the categories into affected or not affected might have been overly sensitive and could have picked up some false positives. So in addition to these findings, the quantitative section also showed that overall there was a relatively high quality of life among the participants, lots of high quality of life subscale scores. There appeared to be few limitations, with energy and fatigue being the most problematic. And then finally, current employment was associated with higher levels of physical and emotional well-being, which suggests that optimizing health in these areas might be important in helping an individual with 48XXYY secure employment. So results from the qualitative strand of the study also demonstrated an overall high satisfaction with quality of life. Physical health was described as relatively positive, but that could be due to the fact that participants frequently compared their physical health to severe disabilities and handicaps. So in this more extreme sense, they weren't perceiving any physical health limitations. And in addition, participants described a variety of psychosocial and emotional health states. So for individuals who described more impactful negative psychological concerns, some described these as co-occurring with fluctuations in their TRT, or in the context of intimate partner or relationship issues. And then finally, social health emerged as being one of the most important factors influencing health and quality of life. When social health was reported as positive, individuals generally expressed higher satisfaction with their health and quality of life. However, when individuals struggled with navigating psychosocial health, it appeared to have a great impact. So finally, as results from both strands were kind of triangulated and all put together here to develop a description of health and quality of life in this sample. So the physical health findings from both the surveys and interviews revealed mainly confirmatory findings. The physical functioning subscale was the highest in the quality of life, and similarly, individuals perceived no physical health problems that were really significant for them. While there were some mentions of the physical problems, the implications of these problems seem to be associated with primarily psychosocial health outcomes. So if you'll think back to that example of reproductive health issues or issues with tremors. Results of the psychological health findings from the quantitative strand had some mixed findings. So while there was a higher frequency of depressive and anxious symptoms, the emotional well-being subscale was high. So it's possible that we have a little contradiction there, but it could be explained by the fact that these negative psychological symptoms were typically only associated in the context of social situations where there were failed friendships or relationships, which the surveys didn't expressly address, but were very common topics in the interviews. An additional finding in the quantitative strand was that independent living was associated with increased depression, which was interesting because in the qualitative strand, the interview portion, independent living was a significant goal for many of the participants. However, it's possible that although many of the participants wanted to live independently, if they were unable to kind of meet those demands of independent living, it might have resulted in increased depression or anxiety. So in general, though, participants reported a relatively high quality of life in both sections of the surveys and the interviews. So in a brief summary, the purpose of the study was to develop a better understanding of how men with 48XXYY perceive their physical health and quality of life. Participants reported a variety of physical and psychosocial symptoms impacting their overall quality of life, including testosterone use, reproductive health, difficulty with intimate relationships, and a desire for independence. Two of the most influential factors on positive quality of life included supportive social networks and positive psychosocial interactions. Overall, though, we learned that participants reported a very high quality of life and life satisfaction. And finally, at this time, I'm happy to answer any questions that anyone might have.